Good morning, everybody. Today we start with Chilomastix mesnili. It's another flagellate in the intestine. These are the textbooks. The online references, CDC and our YouTube channel. And this is chapter 4, the flagellates. We have already finished Giardia. Now we go to Chilomastix mesnili. If you look here, this is the classification according to site of infection, and we are still in the intestine, luminal, but flagellates, not amoebae or amoebas. This is the taxonomy. We are in Sarcomastigophora, but not Sarcodina. Mastigophora itself, Zoomastigophora, the flagellates. We have two types of flagellates, one type in the intestine and the other type in the blood. Now we are in the ones in the intestine, intestinal flagellates. As you see here, these are the 8 flagellates, the intestinal and extraintestinal, which we call atrial, and the red ones are the pathogenic ones. And you see here, we have 3 trichomonas, or trichomonids, we call them, one in the mouth, one in the feces, the stool, and one in the vaginal. Also, it can be in males, in prostatic secretions, the prostate. So we have here 6 and 2. These are the 8 flagellates, the 6 intestinal ones, and the 2 atrial ones, which are extraintestinal. And I have to mention or point out that we have Trichomonas tenax in the mouth, Trichomonas vaginalis in the vagina, and Trichomonas hominis in the stool. 3 trichomonads. We will have them all together in this chapter. It's non-pathogenic intestinal flagellate. It's not going to cause any diseases. This is the life cycle. So you can see here we have the 2 stages, cyst and trophozoite, and both of them can be seen in the stool, which means they are both diagnostic stages. The infective stage is going to be only the cyst because it's hard and can resist harsh environments, whether inside the body or outside the body. So if your food is contaminated with this cyst and your water as well, then most probably you are going to get this infection. So just oral fecal by ingestion, you get the cyst inside through the mouth, esophagus, and then stomach, and then to the intestine. And it's a non-pathogenic colonization. It stays there without doing any harm. These are the 2 stages. This is the trophozoite, and if you see here, the trophozoite is not circular, it's pear-shaped, or sometimes they call it piriform. It has single nucleus, which is in the front, anterior part of the parasite, and it has a karyosome, mainly centric, but can be eccentric. Chromatin, it says here no chromatin, but we can see some chromatin here. We will see in the real images if there is chromatin or not. Cytosome, the mouth here, and this mouth has another flagella here, which is usually posterior, and then we have 3 in the front. 3 anterior flagella. This is the front and this is the back. And usually its movement is stiff and rotary, moving in circles and very shaky. Another diagnostic feature here is that we have a depression that runs along the body but in a spiral shape, which we call a groove here, spiral groove. It's a depression or a fissure, and it's going along the body but in a spiral way. And this helps in movement. Plus, of course, the flagella. So this is the cytosome, the mouth, with fibrils. The fibril is this flagella, the back. The posterior fibril, this one, looks like shepherd's crook. Usually it looks like this. Have a look. Or they call it just open safety pin. And you can see this in the trough and the cyst, both. And even in the cyst, it's more clear. Diagnostic feature, curved posture at the end, So this is how it looks here. Here we don't see the flagella because it's very delicate, very sensitive. So they fall sometimes with staining. When you stain, they fall down. So you don't see them. So it depends on how lucky you are. If they are strong, they don't fall. But here we don't see them, but we see at least the nucleus with caryosome in the middle. And we see here posterior flagella extending away from the body. This is the stage, the cyst. And here it looks like lemon. And it has at the end here, it has a knob. And this knob is usually lighter in color than the cytoplasm. We call it hyaline clear knob. So this knob, some books they call it nipple-like protuberance. Protuberance, something extending out. Looks like nipple-like protuberance. If you see this or that in books, they mean the same. There is a nucleus, only one nucleus. So in this parasite, the trough has one nucleus and the cyst has one nucleus. Usually the cyst in other parasites, they are multinucleated. In this one, both of them have the same single nucleus. Lemon shaped. Cytosome, it has a mouth. Large nucleus like this, 7 to 10 times 3 to 7 is large. Central caryosome, no chromatin, although I can see a little bit here. And if you look here, curved fibril, shepherd's crook, this one, shepherd's crook or open safety pin again. And it's even clearer, more apparent in cyst than trophozoid. So we see this feature in cyst more than a trophozoid, but exists in both. If you look here, this is the shepherd's crook. So if you look here, no chromatin. I can still see some chromatin here. Yes, there is some chromatin. But sometimes these are teaching books. Diagnosis. Usually wet mount. And wet mount with iodine and saline. Saline so that we can see the trough and moving. So diagnostic feature with a spiral groove around. In diarrhea, trough only. Formed stool, you can see the cyst. Semi-solid in between both. This is in 90% or 80% of the cases. Stained smear, you can do iodine, quick, just one drop, or trichrome stain, which is demanding and very long steps and needs experience. Iodine is easy. Sedimentation. Serology, antigen, antibody. Maybe the antigen is okay, you can detect. This parasite is non-invasive. The probability of finding antibodies against this parasite is very low, which means the value of using serology to detect antibodies due to this parasite, the value is very, very low. PCR is the best. Of course, somebody might tell me that we can use PCR only. I think at the moment you have to use the wet mount so that you can see it by naked eye. And this is reference. When you see it, then it's it. PCR, it has some problems, maybe sometimes non-specific bands. If I'm doing in my lab, I will do the wet mount, saline and iodine, plus the PCR. So they can support each other. And this is how it looks. Look, here, this is trichrome. And in both trichrome here, I cannot see flagella. Can you? Here. Not seen. There's no flagella here, no flagella here. We can see maybe there is flagella here in the wet mount. See here? We see two flagella here. And we see the posterior flagella extending a little bit out, the same here and the same here. This is short posterior flagella that extends out. And these here, the ones that extend out, they play the role of trailing. What is trailing? They direct the movement, which way the parasite should go, like a ship. Does it go left? Does it go right? No or slight chromatin. As I told you, there is chromatin. Look here, we don't see caryosome. We see granules here. This one has eccentric caryosome, dot. This one more than one dot, like granules. And no or slight chromatin. This is my idea. The same here. See? Single anterior nucleus, no chromatin, no karyosome, but granules. This one. You can see dots only. And this is another one. If you look here, there's flagella here. Flagella here is very apparent. You can see. This is Giemsa stain. So look, with Giemsa stain, you can see the flagella very nicely. Here there is also flagella, but the shape here is bizarre. Not the normal shape. Here you can see flagella. Cytosome, this one. Here the mouth is seen here. The posterior flagella at the end as trailing. No chromatin. Spiral groove. This is the spiral groove. If you see, this is the spiral groove. You can see the spiral groove and it helps in moving. Maybe due to this spiral groove, it's just like somersaults and shaking and circular movement, rotary movement. That's another one. See, karyosome. I mean, you cannot say here there is no chromatin. Have a look. There is chromatin. And here the same. We don't see any flagella here, but we see flagella here. You know, it's very strange that all the Giemsa, you can see the flagella easily. Although the Giemsa is a simple stain compared to trichrome. Trichrome is demanding. But in all the trichrome we have seen and other types, we did not see the flagella. But in the Giemsa, which is simple, we could see them easily. Look here. 3 anterior flagella, these ones. Posterior flagella, the short one here and here. Single karyosome, eccentric here, maybe eccentric here. I can see some chromatin. The same here. This is not wet mount. This looks like Giemsa. This is trichrome stain, where we see 3 flagella here, 3 flagella here. Here, no flagella at all. No flagella here. There is no flagella, but you can see large nucleus with karyosome centric. The nuclei look centric, eccentric, in a chromatin little bit, slight peripheral chromatin. I cannot say here there is no chromatin. Food vacuoles, maybe this is food vacuole, maybe it's bacteria inside, who knows. And this is the cyst. The cyst, yeah, lemon shaped. Sometimes you see abnormal shapes like this one. This is normal shape with halo around, protuberance, the knob here, hyaline knob. Because this is wet mount, we cannot see the cyst very clearly. Maybe here, little bit. Here also, little bit. Hyaline knobs here, 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 here. This is a nucleus. I can see it little bit here, but here it's very clear. This here, look. In this one, cyst, there is the shepherd's crook or open safety pin. This one also the same. This one also the same. I can see them. Shepherd's crook. We can see eccentric karyosome, maybe centric, this one centric to eccentric with little bit of a chromatin around. Lemon shape. Irregular shape. This is not a usual shape for cyst. And this is the nipple or hyaline knob. And the chromatin, no to slight. And this is the shepherd's crook. 1, 2, 3. Or open safety pin. This is the one. See? Look, when you see this, very unlikely that you will say this is Chilomastix mesnili, unless it's in the epidemiology of the area. So most probably, if I see this, what am I going to do? This looks like Trichomonas vaginalis, Trichomonas hominis. This looks like Enteromonas. This looks like Chilomastix. Which one? I will make diagnosis, flagellate, definitely this is a flagellate, and I will go for PCR. Epidemiology and prevention. This is cosmopolitan. Cosmopolitan means international, worldwide, and it's in warm areas with poor hygiene and sanitation. areas that the sanitation is really poor. Prevention, improve sanitation and personal hygiene. Clean yourself and clean your area and your home. Of course, this is not going to be a one-man show, because everybody has to clean himself and everybody has to clean his home in the area, in the suburb. So it's a collective work. Risk factors. This parasite can be seen in children and gays, homosexuals. Where is it here? Anybody can tell me? This advice and this recommendation is going to apply for all intestinal parasites, not only for this. So intestinal parasites, you have to have good hygiene, protect your food from flies and cockroaches, cover it. If you have a fridge, then it's okay. If not, you have to cover it. Protected sexual practices. These are for some cultures where sex is open. Good sanitation and personal hygiene practices. So all the time, be clean. You, your children, your family, and even the house and the suburb around you. So all of these, wash your hands. Make this a practice. Whether you are at home or in the hospital or in your lab or at work. Washing hands frequently is really something that prevents infections. The first step you do to prevent nosocomial infections. Infections that jump from the patient to the doctor and vice versa. So again, this is the table. On the column here, all the intestinal parasites, and here the characteristics. So Chilomastix mesnili, one nucleus in the trough, one nucleus in the cyst. Pear-shaped or lemon. Lemon is the cyst and pear is the trough. Caryosome can be centric and eccentric. Flagella, 3 anterior in the front and 1 posterior, trailing. Site of infection in the intestine. Motility, rotary or stiff. Circular motion and very vigorous. Stiff, very vigorous. Why? Because we have the 3 flagella, anterior flagella, 1 posterior, and maybe the spiral groove also plays role in balancing the motility. And the same here. Look, this is the second one. 10 to 15, the giardia. Chilomastix mesnili, smaller. 8 to 15, little bit. 10 to 12, 5 to 10. The cyst here is really smaller than that of the giardia. Here may be the same, but the shape will be different. The shape of the giardia, you can never miss. This is all for the Chilomastix mesnili. And now let's go for something else. Let's go for fragilis. Textbooks again. Online references. Flagellates, chapter 4. So far we finished 2 flagellates. Now this is the third, fragilis. Again, according to site of infection, this is a flagellate in the intestine. And according to taxonomy, this is a Sarcomastigophora, Zoomastigophora flagellate. It's here. We are here. Again here, these are the 8 flagellates. Giardia lamblia, Chilomastix mesnili, Trichomonas hominis, and Dientamoeba fragilis. Dientamoeba fragilis is pathogenic. We have a star here, and it's red. Dientamoeba fragilis. It's pathogenic. It's like giardia. Giardia is pathogenic. Chilomastix mesnili is non-pathogenic. This is the life cycle. This has a life cycle that is a little bit unclear. Still not fully understood. Why? Because this parasite does not have a cyst so far. Let's have a look. So trophozoite in feces, that's what they see, which means the trophozoite is the diagnostic. Now we have 2 things which are still not confirmed. One of them is either we have the trough directly ingested, oral fecal, and then it infects us. And there comes the question, how would the trough resist the acidity of the stomach? Some people say that this is with milk. The milk neutralizes the acidity, and this parasite can sneak into the intestine. So the milk plays a role in protecting the parasite from the acids in your stomach. Or some of them, they say that this parasite can play like a Trojan horse. It mounts other parasites and sneaks with these parasites into us. And the most commonly encountered parasite that Dientamoeba fragilis parasite mounts or sneaks in is Enterobius vermicularis. This Enterobius vermicularis is a nematode, intestinal nematode, and it has an egg. And this parasite, the trough, goes inside the egg or on top of the egg and sneaks through with the egg into our intestine. These are just speculations, explanations of what might be the case. They are not sure. And even some people, they are saying this might have not cyst stage, but what we call pre-cyst stage. Is it so far fully clear? No. So direct oral fecal transmission, or we might have possibility. This is what we call an assumption, that it might have pre-cyst stage and or the other hypothetical transmission is that it mounts on the Enterobius vermicularis eggs, a nematode. Binary fission, so inside when it gets in stomach, protected either by the milk, as we said, or it might have pre-cyst stage, or through this parasite Enterobius vermicularis, any of these, and then gets inside the intestine. And once in the intestine, one, come two. We call this binary fission. Trophozoite in lumen of colon, the large intestine. Trophozoite. So we have trophozoite. It's round or irregular shape, 3 to 20. You can imagine 3 very, very small, or even 20, like Dientamoebas. No peripheral chromatin, but chromatin granules. It doesn't have any peripheral chromatin, but it has them in the form of granules. Nuclei seen by stain only. And this is the case for almost all parasites. Wet mount, saline, difficult to see the nucleus because the nucleus is mostly DNA, and DNA is colorless. The nuclei seen by stain only. Look here, it has 2 nuclei. We don't have karyosome, we have granules. Dientamoeba. I mean, one of you might ask me, why is this in the flagellates, not with the Dientamoebas? It was once with the amoebas. And later on, under the electronic microscope, they saw some flagella, small. So they brought it from Dientamoeba and put it with flagellates. And why di? Because it has 2 nuclei. Dientamoeba fragilis. So now you know that it was one day classified as with Dientamoebas. So science changes. You have to follow. Bacteria inside, eaten. Chromatin, 4 to 8 granules. I mean, we have here 2 nuclei, trichrome. It's bizarre shape. See, it's extending. And here, if you look at it under the microscope, it's difficult to tell that this is Dientamoeba fragilis. It looks like a debris, artifact, dirt. So if you look at it, you will never say this is a parasite, especially if you know that the nuclei, they are not seen. You will never think this is a parasite. For this reason, a good lab should have PCR there all the time. 2 nuclei, pseudopod, and look, some of them, mostly 70 to 80%, they have 2 nuclei. To 30%, they have 1, and rarely they have 3 to 4, very rare. So let's stick to 2 nuclei in most cases. No cyst stage, possibly there is pre-cyst, so I'm not going to elaborate very much on the cyst. We already talked about this. So it's just hypothetical, possibility. Morphology, that's how you see it. This is the wet mount, and if you don't see it moving, this looks like nothing. Unless you make a stain, and here you have one nucleus, here we have two, here we have two, here we have two also, here we have one. The nuclei not seen, this one, shape variation, misdiagnosed as debris. When you look at them, you see them like debris. Because it blends well in the background. It merges very easily with the background. Like camouflage, you know. If you look here, iron hematoxylin stain. It's the only one that is used to demonstrate the granules inside the nucleus. Not Gimza, not trichrome. Iron hematoxylin. Two nuclei here, and here also. Pseudopod. What are the parasites that use pseudopod for movement? Amoebas. Therefore, it's not strange that they one time classified this as amoebas. So chromatin granules, these here, they are seen with or visible with iron hematoxylin. Diagnosis: wet mount preparation. It's not good to use because it's not going to give you any added value. The parasite looks like the background with debris and artifacts, so don't use it. Stain smear is much better. If you suspect that you are dealing with Dientamoeba fragilis, then make stain smear. Trichrome, Gimza, iron hematoxylin, any of these. This is the easiest, and these two, they are demanding. Don't do concentration because concentration and flotation are usually for cysts. And here we don't have cysts. So stain is the best here. You have to stain. Antigen, antibody. You might detect antigen with ELISA, but antibody, it is pathogenic, but doesn't invade the intestine to the blood and other organs, so that antibodies are formed. So antibody serology, not very well used. Histology, stain smear, no. PCR is, yes, most sensitive. Therefore, if I were you in a lab, we make stain and then we do PCR. The mode of transmission is, as we said, you remember when we discussed the life cycle, we said that the life cycle of this parasite, this flagellate, intestinal flagellate, is not well understood. It's not clear. Therefore, the mode of transmission is going to be the same. Speculations and hypotheses. First, mode of transmission via Enterobius vermicularis egg, the nematode. It's just like a Trojan horse. The trough of this parasite flagellate, fragilis, D. fragilis, mounts the Enterobius eggs and gets inside our body. Or direct oral fecal by ingestion and eating. As we said, this parasite might have cyst or pre-cyst stage. Still unclear. If it has cyst or pre-cyst stage, then we might have infection through this cyst or pre-cyst stage. This is reported in animals like pigs. Epidemiology. This is worldwide and without specific geographical areas due to vague life cycle, due to unclear life cycle. We have to understand the life cycle of the parasite so that we can prevent ourselves from getting this parasite. And here, since the life cycle is unclear, prevention methods also are unclear. So we cannot give recommendations to people, except mainly maybe the hygiene. Have good hygiene, personal and the area around you. Symptoms. Mostly asymptomatic, like Giardia lamblia, giardiasis. So you might have it and you don't notice this. If there is going to be symptoms, then these are going to be abdominal pain, diarrhea, vomiting, flatulence, gases, weakness, weight loss, constipation, difficulty in defecation, fatigue, general weakness and exhaustion, fatigue. So if you look all of these here, all of the symptoms you see here are general. They are not specific. We have talked about the same symptoms in giardiasis and also the same symptoms in amoebiasis. So these are not something specific. When you have them, then there is a problem. This problem could be viral, could be bacterial, and could be parasitic. And if parasitic, could be amoebiasis, giardiasis, or maybe this here, D. fragilis. Nothing specific. Treatment, we have metronidazole, which is the one that we used for the amoebas, if you remember, and the one that we used for giardiasis, and the one we are using here. So metronidazole, which we call Flagyl, is very common antiparasitic drug. There are others, like tetracycline, which is antibiotic. But tetracycline, you have to make sure that you don't use it for children below 8 years old, and you shouldn't use it for women who are pregnant, because it affects the teeth of the children. Paramomycin and iodoquinol. Prevention advice, this applies to all parasitic diseases, which we talked about in earlier lectures. Avoid night soiling, which is fertilizing using human poop or human feces. Protection of food from insects like flies and cockroaches. Be protected sexual practices for those communities who have abnormal sexual practices. Good sanitation, whether personal or the surrounding, and give veterinary care. Give health care to animals, whether these animals are pets or livestock, animals which we make use of, like sheep, goats, poultry, sometimes use. Again, health awareness is a cornerstone. You have to be aware of the parasite's life cycle. If you know the life cycle, easily you can prevent. Hand washing is all the time cornerstone. If you look here, the differential morphology characteristics, the column here is the parasites and the row the characteristics. D. fragilis. In nucleus and cyst, we are not sure that there is a cyst. 1 to 2, 80% 2, 30% 1, and less than 5% can be 3 or 4. The granules, karyosome is in the form of granules, not dot like the other parasites. Shape of trough is irregular. That's why it blends easy in the background. So if you use the wet mount, difficult to make diagnosis because it looks like artifact and debris, as we said. Peripheral chromatin, no. It doesn't have flagella or undulating membrane, although microscopically they have seen these small flagella. And it was because of this they brought this parasite from the amoeba family and put it in the flagella family. So we don't have flagella, but under the microscopic, very small. Site, colon and cecum, large intestine. Motility, progressive. It moves like pseudopods, like amoebas, although it's intestinal flagellate. Morphology, panoramic view. These are the troughs and cysts. So if you look here, fragilis, 3 to 20 micrometers, no cyst stage. So this is the end of this parasite.